Good evening, guys. Welcome to our channel, and today we'll be discussing Harlequin Icthyosis as part of our requirement in Bio 130 Genetics and Embryonic Development. So to begin, we'll be discussing an overview, basically asking the main characteristics or discussing the main characteristics of this disorder. So to begin, we have our medical operation definition. Harlequin Icthyosis is the most severe and frequently lethal form of recessive congenital ichthyosis. This disease is characterized by profound thickening of the keratin layer in fetal skin, and the affected neonate is born with massive, horny, and dense plate-like shells along with contractile defects of the eyes, ears, mouth, and appendages. To begin with, let's discuss a little etymology of the words, trying to know its origin. So Harlequin Icthyosis actually has quite interesting origin. The term harlequin, as you may be familiar with, is from the French harlequin, meaning jester. It derives from the pale appearance, the diamond keratosis right here, and the pulled mouth, all mimicking a clown's face and a clown's smile. Now, the second term is ichthyosis, from the Greek ichthyos, meaning fish. This derives from the keratin plates, which resemble scales, as well as fish-like facial appearance of those affected neonates. Next, we'll be moving on to the 6 common symptoms of Harlequin Icthyosis. Among these, being the first, is skin reddening, otherwise known as congenital ichthyosiform erythroderma. Second is a depressed nasal ridge, leading to a flattened nose. Third is the outward turning of the eyelids, technically known as severe entropion. Fourth is abnormal hearing, often caused by the impaired growth of the ears. Fifth is the hyperkeratosis, or the depigmentation near the eyes and around the skin. Last is respiratory restriction, where the breathing is made difficult upon encasement of the keratin plates.
Alright, now let's move on to the etiology, or what exactly causes this disease. We now know that this disease is caused by mutations in the ABCA12 gene and that it follows autosomal recessive inheritance. So what exactly does the ABCA12 gene do? Well, this gene codes for a protein called the ATP-binding cassette transporter, which has the job of carrying different molecules across cell membranes. It is through this ABC transporter that lipids are released into the intercellular spaces and are brought to the surface of the epidermis. So why does this need to happen? Well, as we know, lipids are very hydrophobic molecules, and so they do a really good job at keeping water inside the body. Apart from that, well, lipids are also important for proper epidermal development. As we can see in the image to the right, the skin is kept hydrated by a healthy amount of epidermal lipids. It so follows that mutations regarding this gene can cause one of two things. Either it can cause the total absence of your ABC transporter, or it can cause the production of abnormally small versions of this protein. And both of these lead to the accumulation of lipids in the stratum corneum. It has been suspected that the mutations are intergenic and frameshift deletions in nature. Hence, lipids are deposited within the epithelial cells and take the form of cholesterol-like crystals and autophagic vacuole masses. On the image to the right, we can see an example of cholesterol crystals.
Now, after tackling the etiology or the origin of the disease, we now go to the epidemiology, or the prevalence and frequency of said disease. Now, studies in the United States have indicated that 1 in every 500,000 people are affected by Harlequin Icthyosis. They have tried to correlate effects of sex and race to said disease, but however, no racial or sexual predilection has been found or known. However, theoretically, higher incidence may be encountered in cultures where parental consanguinity, simply put incest, is common. Given that, you may now be wondering what the prognosis is for this disease, meaning what are the chances of survival for people afflicted with Harlequin Icthyosis. Well, good news is out. Moderately high figures with worldwide averages approach 50% survival rate for people afflicted with Harlequin Icthyosis. In a related study of Japanese and US residents, the review of 45 cases yielded 25 survivors ranging from 10 months to 25 years old, meaning there were another 20 deaths from said cases, and that occurred from day 1 to 52. These deaths from Harlequin Icthyosis were equally likely to be caused by respiratory failure, septic shock, or a combination of both. Now we move to the diagnosis of the disease, meaning how we identify the manifestations of Harlequin Icthyosis symptoms. Well, there are 3 prevailing methods currently practiced in medicine. First is a prenatal ultrasound, basically an ultrasonography during the 3rd trimester. Second is genetic testing, a prenatal testing for mutations in the ABCA12 gene. Last is a physical examination or the inspection of the neonate upon its appearance on birth. Now let's discuss the diagnostic measures in detail. First, we begin with the ultrasound, particularly a three-dimensional prenatal ultrasonography, which has been proven useful in the diagnosis of infants with no known familial risk or history of Harlequin ichthyosis. The ultrasound identifies characteristic features present in the affected neonate. So among these are the large and gaping mouth, aplasia of the nose, abnormal limbs, bulging eyes, rudimentary ears, growth restrictions, and flexion contractures, and lastly, floating particles in the amniotic fluid. Seen to the right are some manifestations of these said features. Second, we move to an equally effective method of diagnosis called genetic testing, which is done via the complete sequence analysis of the coding region of the ABCA12 gene in order to identify specific mutations. The samples, as seen in the picture on the right, are often isolated from prenatal peripheral blood cells and often obtained through the amniotic fluid. Alternatively, if one does not wish to perform this procedure, cross-referencing from the parental buccal smear, that is called the cheek smear or mouth smear, that can reveal the risk of transmission by tracking the ABCA12 gene across both parents. Lastly, if these preventive diagnoses are not done, then what we are left is a physical examination of the affected neonate. So the disease, as we have said earlier, primarily affects the skin. However, several other organ systems may be significantly compromised by the hyperkeratosis and concomitant deformities present in the Harlequin ichthyosis infant. As such, various findings may be noted upon neonatal physical examinations, which will be elaborated in the later tables.
Alright, so we define key differentials as the physiological manifestations that are more or less exclusive in certain diseases. So as we can see in this table, the key differentials for Harlequin ichthyosis are they range throughout many different organ systems. For the skin, most evidently, there is a formation of thick, shiny plates that are separated by red and white fissures. It is these fissures in between that render the person affected susceptible to skin diseases and recurrent skin infection. We can also see here in the next three items that Harlequin ichthyosis gravely affects your sensory organ systems. For the eyes, as has been mentioned earlier, there is severe ectropion, wherein the free edges of the upper and lower eyelids are everted due to the tension on the skin. As such, the conjunctiva and cornea are at risk of dryness and trauma. Next are the ears. The ears are described to be flattened and obstructed by scales, and this can cause impaired hearing. For the nose is flattened and there is depressed nasal ridge. This in turn can cause impaired breathing. Finally, for the limbs, there is the encasement of the limbs, which results in limited growth. Adding to this, the limb mobility is poor due to muscle malformation and swelling. In very severe cases, this can cause the death of limbs or digits.
Now, with Larkin having discussed the key differentials, we now move on to the secondary systemic effects, these being the negative impacts of said symptoms on related physiological functions or organ systems in the body. We begin with temperature regulation. Now, the thickened skin prevents the normal sweat gland function and heat loss of the infant. As such, the infant is heat intolerant and can become hyperthermic. Second, it affects the respiratory status, meaning that the restriction of the chest wall, often due to the keratinous plates, will result in a respiratory distress by inhibiting the expansion of the chest walls, thus often hypoventilation and respiratory failure. Third would be hydration. The dehydration from the excess water loss due to the ineffective skin can cause tachycardia and poor urine output. Fourth, it also affects the central nervous system. How? Well, the metabolic abnormalities can cause seizures. The CNS depression is itself a sign of sepsis or hypoxia. And lastly, the hyperkeratosis may restrict spontaneous movements, making neurological assessment of reflexes difficult. Lastly, circulation is also negatively impacted. How so? Well, the restriction of blood flow due to the keratinous plates, once again, in the extremities may cause digital necrosis and limb death. So now we arrive at the last segment of our discussion, namely the treatment, discussing what the prevailing methods are for managing this disease. We know that newborns with Harlequin ichthyosis require management in a level 3 neonatal intensive care unit. What this simply means is it needs a lot of resources to manage this disease. The most prevalent, and they say the only effective treatment as of now, is systemic retinoid therapy. Now, retinoids, what are these things? Well, these retinoids are chemicals that bind to specific retinoic acid receptors, and then they regulate the gene transcription of certain genes that first downregulate keratinocyte differentiation and proliferation, thus lessening the thickening of the dermal plates. And second, they mediate the desquamation of the hyperkeratonic scale and also leading to a decrease in the dermal plates. So now, Larkin, what do you think about the consensus of the doctors?
Well, there are three main findings regarding this. First is it has been found that there is enhanced survival and decreased morbidity as that results from retinoid therapy. And it is known that in tandem with this therapy, there is the use of emollients which ease the shedding of the thick plates. However, the extension of the lifespan of a person that receives this treatment is only lengthened until early adulthood, and their deaths are not usually due to the thickening of skin per se or any direct effect of the disease, but are caused by the infections that this disease allows.
In other words, it's not the primary symptoms that cause the death or the ailments, it's the secondary systemic effects that cause these. And one example would be the call for the need of neonate surgery. So what happens here is that due to the thickening of the keratin plates, there is a big risk of limb, nasal, and circulatory constriction, as said earlier, due to the hyperkeratosis. And this can call for surgical treatment, not only in an infant's life, but also throughout in the later stages of his life.
All right, so we know that the epidermal and dermal release can relieve the neonatal compartment syndrome, which prevents ischemia and possible limb loss.
But then, to reiterate Larkin's earlier statement, as we go through later in life, it becomes more and more difficult to regulate the thickening of the plates, to prevent systemic infection, and to prevent the ailments caused by the hyperkeratosis. So now we arrive at the end of our segment with these references, and we would like to thank you, our viewers, and we hope you had a fun and enjoyable time. Bye, Ma'am Maggie!
Bye, Ma'am Maggie!
We'll miss you. So ito na, like and subscribe. Bye!